Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Post on two things. One is the number of children who have lost their parents or grandparents in the last year and a half. And I was amazed at how many children have faced the death of both of their parents or grandparents. Any idea how many kids because of the pandemic?
You want a percentage?
A number of children who have faced the death of their
In
significant.
the country?
Yes.
Oh, I would say about 10,000.
Okay. Any other thoughts?
15.
15,000?
Mhm.
Okay. Any other thoughts? Carol, you silent.
Giving me the silent treatment. It's good to see you, John Buchanan.
Good morning. I would say
Hey.
5,000.
Okay. Nobody's even close.
100,000. I'll go up.
Okay.
50.
Dennis?
50,000.
Okay. All right. Joyce Brenfield Sanders.
It came in on the end of the conversation. I'll just throw out 20.
Yeah, we're talking about how many children have lost their parents because of COVID in the United States.
I'll raise that to 60.
Okay. All right. Anybody not spoken? Because Darryl, are you with us? I see your keyboard.
No, he's not there.
Oh, okay. The answer is 1.5 million.
Wow.
Gosh.
My goodness.
Oh my gosh.
Yeah, 1.5 million. Can you imagine the impact on children? COVID.
Dad. Oh.
Well, I had a question about that. I thought the maximum was, I thought it was 600,000.
People who died, right?
Yeah.
But
So how can it be a million?
no, we said the question was how many people have died. We said how many children have lost their parents or grandparents. So if you have a family of 4 or 5, see,
Yeah.
you have multiples,
Yeah.
Okay.
and that's why
So
it's up to 1.5 million, because
it-
the average
it's not
family is
the-
about 3 or 4. So
okay, it's not the deaths, it's the children.
that's right, the impact on children.
I thought the average family was 2.5.
Even that 2.5 is that'd be about 1.5 million.
Yeah.
Because 600,000 deaths. And yes, so we're talking about astronomical figures, which impacts
Yeah.
upon how they go to school and everything else, their
Yeah.
education, everything. Yeah. And lo and behold, we have Dr. Tom Sabisa-san with us. And he's a geriatrician of international renown, and famous doctor and incredible researcher who's blessed us with his presence. He was with us more than a year ago, and we were so blessed to have him that we asked him to come and discuss again, because we're in the age group that he takes care of. And so we'd like you to educate us again. Welcome today again, Dr. Bisa.
Thank you. Good morning, Dr. Callender, and good morning, everybody.
Good morning.
Glad to see all of you. Do I have the podium, Dr. Callender? Yeah.
I'm sorry?
Do I have the podium?
You got it.
Oh, okay. Okay. Good morning, everybody, and I'm delighted to see all of you looking well. That you all made it through the pandemic, even though the pandemic is not yet over. But Zoom, you're doing everything you can to protect yourself and your family. Again, I appreciate the opportunity to share a few points with you today from a geriatrician standpoint. Because this is not a lecture per se, but more of a dialogue, I don't necessarily have a set of slides to share with you. But my intention is just to engage in a two-way discussion with you. Perhaps I should begin by a few observations on things that I think are of utmost importance as we get older. And then perhaps give you the opportunity to ask questions so that we can have a two-way discussion. Because I don't necessarily know what your individual desires for information are. So let me begin by talking about highlighting a couple of areas that I think are of specific interest as we get older. The first one is physical well-being. Again, as we get older, you will realize that regardless of who we are going to start losing muscle mass. Muscle mass is the number one determinant of ability to ambulate. And once we lose the ability to ambulate, it's almost like a spiral downward turn from that standpoint. What can you do as we get older in order to prevent this spiral downturn? First of all, you must at all costs prevent any opportunity for falls because falls is a major, major cause of morbidity and mortality in older adults. Once somebody falls once, they are afraid of walking and therefore their limitation, their ability to ambulate and their desire to ambulate decreases exponentially. So your first task is really making sure you avoid falls at all costs. And how do you avoid falls? Well, the first thing is to really look at your individual home environment to identify things that may potentially predispose you to fall risk. Now, there are individual risks and there are environmental risks. The individual risk, as I alluded to, is muscle mass, which is the number one determinant of gait and balance. There's a process called sarcopenia that occurs with advancing age, regardless of who we are and regardless of how much physical activity we do. Obviously, if you are engaged in resistive exercise training, you can retard that process. But my focus this morning with respect to fall prevention is more on the environment. How do you assess your environment and what do you do with your environment to ensure that you reduce the risk of falls? Number one, you have to make sure that your house is rid of any clutter, that there are no clutters anywhere in your house because clutters are a major, major risk factor for fall. Make sure there are no furniture across the hallway. Avoid, I know we love all those oriental carpets that makes a home beautiful. If you have a floor that may be slippery and you have oriental carpets there and you slip and fall, potentially you can break your hip, you can have head injury, bleed into the brain, and from that point on, it's a really, really deep downward spiral turn. Make sure, I know many of us don't use land phones anymore, but if you still use land phone, make sure there are no telephone wires running across the hallway. No electrical wires across the hallway, that the house is well illuminated. Perhaps it's useful during the day to make sure that the windows are open. I know we may be trying to conserve on our electricity bill. If the windows are not open, the lights must be on to make sure that you can see very, very clearly. It's also important that you get your eyes properly checked to make sure that your visual acuity remains optimal, because if you can't see very well, then potentially you're going to be bumping into things. On occasions, depending on individuals, we do advise that you may install grab bars in the toilet as well as in the bathroom. Grab bars are things you can hold, bars that you can hold onto as you get in and out of the tub, because that is one of the most important places where this type of force do occur. You may also consider a raised toilet seat, and as well as a seat in your tub, so that when you're in the tub, you're not just standing, you are sitting, so the risk of slipping and falling becomes minimized. You should also have a non-skid mat in the tub. Again, all those things will potentially reduce the likelihood of falls. And depending upon your situation, at some point, it may be useful to move your bedroom to a lower floor. If you have to climb stairs or go into the bedroom or come out of the bedroom. So those are some of the things that you can do with your environment in order to prevent falls. In addition to that, you also have to be attentive to your medication. We come to polypharmacy at some point during this discussion, if time allows. Because if you, low blood pressure is just as bad as high blood pressure. So if you are not optimally compliant with your medication, you're taking it haphazardly, and your blood pressure is all over the place. Sometimes it's too low, sometimes it's too high. If you get up in the morning, then potentially your blood pressure can drop, and that can lead to fall. There is a process that we call the baroreceptor reflex in older adults. That is, for any individual, as you get up from a sitting or lying position to a standing position, there is a baroreceptor reflex in your neck that kind of senses the amount of blood that is going to your brain. And very quickly, in younger individuals, that reflex sends signals to your heart to pump harder and to beat faster, so that you can maintain the same level of blood supply to your brain. But unfortunately, as we get older, that signal becomes delayed. The signal is still there, but it takes much longer time for it to respond. And these are not responses that require minutes to occur. They are responses that occur in milliseconds. And those milliseconds can be very, can be critically important. So that is for prevention. In fact, if I don't say anything else today, if there is one single thing that I know you can prevent and that can have very dire consequence, is fall. If you're able to prevent fall, you have done a very good job of preserving yourself and making sure that you optimize your well-being. In addition to fall prevention, one thing that is tied very closely to fall prevention is exercise. I don't know of any medication to date that has the effectiveness of exercise. Aerobic exercise mostly, but also resistant exercise can be quite beneficial. The magnitude and the scope of the effect of aerobic exercise on our physical and psychological well-being is really just mind-boggling. So even if you can manage a little bit of exercise daily, whatever type of aerobic exercise you can do, it does not have to be running. It could be fast walking. It could be just going for a stroll in the evening. In as much as you're able to get your heart rate up a little bit, I think that is also quite beneficial. It reduces your cholesterol, it optimizes your blood pressure, it enables your blood sugar to be better, easily controlled. It enhances your cognitive well-being. It enhances your psychological well-being also, because exercise does enable the release of neuroendorphins that tends to play a very, very vital role in our self-actualization and emotions and happiness. So the effect of exercise is quite incredible, and is one medicine that I think everybody should take every day. Uh, Perhaps it's even more important than the medicine that your doctor might have prescribed for you. The second of the 4 items that I want to underscore very briefly is psychological well-being. Psychological well-being is critically important as we get older, because it's what is going to enable your cognitive function to be optimized, as well as even your physical function. It does play into your function. Social isolation is a killer that we must prevent at all costs. Social isolation has a myriad of consequences, because if you are alone by yourself, obviously, nobody knows what's going on with you. It means you're probably not socially engaged. It means you are not exercising, that is, going to a wellness center, going to churches, taking a walk in the evening. It means you are not really very connected with family members, friends, and church members. Social isolation kills the brain very, very quickly. And if you are not moving around, then your muscle mass is going to degrade very quickly. Your nutrition is going to suffer, and depression is going to step in very, very quickly. And again, that creates a very, very serious spiral downturn. So whatever you can do, I think you do have control over whether you socially isolate yourself or not. There are so many disease ailments and predicaments that, depending on who we are, genetic predisposition, lifestyle, and so on and so forth, that creep on people as we get older, that you don't necessarily have so much control over at this stage in the ball game, except to make sure that you seek care and take your medication. You do have control over social isolation, to not socially isolate yourself, because it can be very, very, the consequences can be very dire. And then a very close ally of social isolation that is worthy of mention is depression and anxiety. I think in our population, in our communities, that we still think about depression as something that comes with some level of stigma. In 2021, we really should not be thinking about depression in that context, because for all that you care to know, is not different from having diabetes, from having high blood pressure. Basically, a function, a consequence of neurochemical imbalance in the brain, and therefore is just as treatable as those other disease ailments that I mentioned. So when you go to your doctor, it's critically important that your doctor does take some time to assess your psychological well-being, to make sure that depression and mood disorder is not playing a role in your social and psychological well-being. So what are the consequences of depression? It's almost the same, as I said, a close ally of social isolation. It's almost the same as social isolation, because if you are depressed, then you don't want to interact with other people. You want to be by yourself. If you are by yourself, you are not socially engaged, you are not going out, guess what's going to happen to the muscle? The muscle is going to degrade very, very quickly. Before you know it, you may not be able to walk. What about your nutrition? Your nutrition is going to suffer. If your nutrition suffers and your muscle mass is degrading, guess what's going to happen? Before you know it, you may not be able to walk, just because of depression, something that is, I will not say simple, but something that is very, very treatable, at least in this era that we're in. So depression has a lot of consequences, including Also, not taking your medication. So if you are depressed, you're not going to church, you're not going out, you're not taking a walk in the evening, you're not eating well, the chances are that you're not taking your medication as you should be. And because depression affects concentration, you lose ability to concentrate and then to be thinking, oh, my memory is going. If I give you a couple of $100 and I ask you to keep it somewhere in your house, and you take that money and you are so depressed that you're not even thinking about where you put the money, I can guarantee you can spend 3 days from that time looking for the money and you won't be able to find it. The simple reason you can't find it is because because of depression, you are unable to concentrate. You lost the ability to concentrate. Therefore, you are not paying attention. You put that money away, and then you'll be looking for it all over the place or thinking that somebody stole the money from your house. And that can actually also be a prelude to memory loss. So depression has very, very dire consequences. It can be easily screened for, and it can be easily treated. And in this damn age, it should not be something that is going to cause the beginning of the end for any of us, because it doesn't deserve the kind of stigma that it gets. So that also leads me to the issue of memory disorder, because as I said, depression can cause memory disorder, social isolation can cause memory disorder. I know when we hear about memory disorder, we generally think about Alzheimer's disease. But you're by no means wrong, because Alzheimer's disease is the most common type of dementia, which is why the name Alzheimer's disease seems to be synonymous with dementia. What can you do to prevent or retard or slow down or reduce your risk of developing Alzheimer's dementia? Fortunately, most of the things that we've been talking about so far are very closely tied together, because we know for a fact that physical activity by way of aerobic exercise can enhance brain perfusion, that is blood supply to the brain, can enhance potentially amyloid clearance, and reduce the likelihood or the progression of memory loss as we get older. Obviously, exercise will reduce your risk of developing, we enhance your ability to control your cardiovascular disease risk, such as lipid, diabetes, hypertension, all of which have been shown to contribute to the risk of developing memory loss. Brain aerobics is very, very important. What do I mean by brain aerobics? Doing crossword puzzles, getting socially engaged, learning new things. There was a recent, well, not so recent anymore, there was a publication in the United Kingdom on the taxi drivers a couple of years ago that showed that taxi driver tends to have a bigger hippocampus. The hippocampus is the part of the brain that is responsible for acquisition and storage of new information. Why do taxi drivers have a bigger hippocampus? Because they're constantly out there surveying the environment, challenging their brain, trying to navigate, interacting with people. All these things are very, very important because we are not as social members of the planet. We are not created to be by ourselves. We are created to be among people and constantly challenge our brain. So it's very, very important that you continuously challenge the brain. This may be the time for you to start learning how to play piano, if that is something that is of interest to you. This is even the time for you to start learning how to program, write computer program. I mean, you're not doing it for money, you're not doing it to impress anyone. You're just doing it to challenge your brain. Anything that you can do to challenge the brain, to keep the brain active, is critically important. So that's for cognitive dysfunction. And again, there are some aspects of it that we may not yet be able to do anything about. I don't know whether any of you have been listening to the news. For the first time in our history, we actually now have a medication that recently came to the market that does attack the cause, the underlying cause of Alzheimer's disease, as against treating the symptom. It is by no means perfect, and it is by no means panacea. It's by no means the ultimate of what we're looking for. But for the first time in our history and history of research on memory disorder, we have a medication that can potentially stem the underlying process of memory deterioration as we get older. The third item that I want, perhaps maybe again, so that the issue is not lost in the long drawn out, monotonous one-way discussion. If anyone has any question as we go along, because this is kind of a discussion format, it may be useful to raise those questions, or alternatively, you can write them down so that at the end of my observation, we can have a very brief back and forth dialogue. The next one that I want to touch on very briefly is pharmacy. Again, as I said, why it may not yet be possible to cure diabetes, to cure hypertension, to make hypercholesterolemia go away, to reverse stroke and all these terrible illnesses. One thing that you can certainly do is to make sure that your medication is optimally managed and that you reduce the risk of polypharmacy to the extent possible. What do I mean by polypharmacy? Anybody who's taking more than one or two medications has polypharmacy. Remember that each of the medications that you take has their own unique side effect profile. And this side effect profile tends to be exaggerated as we get older for a variety of reasons. That reason could range from what we call the absorption of the medication that may be different in older adults as we get older. Could be the distribution of the medication because many of us are not drinking enough water. So that medications that are soluble in water, we have a higher concentration in older adults because we are not drinking enough water. Also, medications that we consider lipophilic, that is medication that are soluble in fatty tissue, tend to have a larger volume of distribution in older adults as we get older. And the simple reason for that is that even though you may not be seeing a lot of fat on your hands, on your skin, under your arm, and so on and so forth, there is redistribution of that fat from the periphery to the central region. And drugs that are highly soluble in fatty tissue tend to hang around for a much longer period of time. It's the reason why we avoid medications like a long-acting benzodiazepine, like Valium, that we tend to avoid the use of those medications in older adults. Again, for medications that are water soluble, the digoxin is one of such medications. I don't know if anybody here is on the digoxin, which tends to bind to muscle as well as soluble in water. Those two things makes controlling the toxicity of the digoxin quite challenging in older adults. I just named a few of these medications to underscore my point. The other thing is that the partition between the systemic circulation and the brain becomes less efficient as we get older, which means that medications that have the ability to be active in the brain have a tendency to have higher concentration in the brain because the firewall between the rest of the physiology and the brain becomes compromised as we age. So medications that are centrally acting that cross the blood-brain barrier tends to cause a lot more problems in older adults. And if any of you is on catapres, you should talk to your doctor about potentially changing that to something else because it's one of such medications that is centrally acting and tend to cause a lot of confusion in older adults. Also, as we get older, the kidney becomes less efficient. I know you are the transplant group. The liver itself becomes less efficient. The certain parts of the liver that metabolize medication becomes less efficient, which means that the toxic effect of some of the medications that we take becomes prolonged and hang around the body for a much longer period of time, which is why we need to be quite circumspect and be attentive and make sure that we continuously dialogue with our physician to make sure that we reduce the number of medications to the extent possible. The kidney also becomes less efficient at clearing because most of the medication we take leave the body through the kidney. The kidney also becomes less efficient at getting the remnants of that medication out of the body. As we get older, the albumin, the protein in our body that carries medication from one point to the other, also becomes low. And because it's low, and because it's the part of the medication that is not bound to the protein that is active, if you have low protein, then you will have active component of that medication in your system. And then the more of that medication you have in your system, the more activity that medication is going to have. So those are some of the reasons why polypharmacy is a critically important issue in older adults. Be careful about over-the-counter medication. I will line this segment by saying that every time you're going to see your doctor, you must take every medicine that you take, regardless of who prescribed that medicine or whether you are the one who prescribed that medicine for yourself. By that, I mean over-the-counter medication. Every medication that you take, don't believe for a moment that because you bought something over the counter that it doesn't have side effects. Every medication that you take has its own unique side effects. And the more you take, the more likely there are going to be interactions among those medicines. So for a very attentive clinician, geriatrician, the most important task is making sure that that number of medicine is reduced to the extent possible. And sometimes it may not be possible to discontinue certain medications, but we always try to kill several birds with one stone and make sure that medications that are not necessary are not taken. And also that you are not taking expired medication and that you are not taking duplicate medication. Because sometimes the names of the medicine or the actual tablet may seem different to you, but they could be doing the same job. So the only way you will know that if you take all that medicine to your doctor when you are going for a visit, and make sure that your doctor take a look at all those medications and reconcile them to make sure that wherever medication he or she can take away, or whatever medication he or she can combine into one, that will be done to optimize your well-being. Again, as I said, you may not be able to really make the underlying medical illness go away, we certainly can make the management of that illness become optimized, not cause any additional problems by drug-drug interaction and multiple medication and polypharmacy. And we can't get into the specifics of food-drug interaction today, but you also have to be attentive to yourself and to the food you eat with respect to the medications that you take. The last thing I will dwell on very briefly, which I'm very sure you must have discussed at some point, is advanced directives. It's critically important that each and every one of us have a written advance directives that is legal, and perhaps also in that have a durable power of attorney, just in case you decided that you want somebody else to make decisions, even while you are still capable of making those decisions. Decisions about life support, decisions about finances, decisions about medication, decisions about any kind of thing that you may encounter in your life journey. Let me conclude with a subject that you may not have discussed much about, which is wealth transfer. We do not, as minority population individuals, this is not a place where we have thrived historically. As a geriatrician, I've been in several situations where I find children fighting over whatever it is that their parents left behind, and invariably, whatever it is goes to a counsel, an attorney. I don't know if that is really optimal, if that is the legacy we want to leave, since traditionally we really have not had a lot of generational wealth and transfer. Whatever it is you have, it's most appropriate that you think very carefully and decide how you want things to be handled. Otherwise, you're going to find people fighting over whatever it is. And before you know it, an independent counsel is going to be assigned who is going to be managing that resources and deciding who gets what. And in many cases, majority of that is spent in the process. It hurts me very greatly in situations that I've had to deal with some of these type of issues when I find siblings, relatives fighting over this kind of stuff, and in the end, they get nothing out of it. So I think it's an issue that is relatively dear to me, again, given historical perspectives. I'm not necessarily saying you should do one thing or the other, but I'm just saying that you should think about it creatively such that it doesn't become a source of discord when we cease to have the capacity to make those determinations. I will stop there and we can spend the rest of the time on a question and answer. Thank you for your attention.
Thank you very much for that very provocative talk. I actually have about 4 questions, but I will just start off with reminding everybody that August is National Minority Donor Awareness Month. And so to the last discussion that he mentioned, keep that in mind. My first question, though, is what age do you have to be to go to a gerontologist? Is there an age for which you, below which you don't take patients, or is there an age above which you don't take patients? I think that was one of the first questions I wanted to ask. The second was relative to what is your opinion of the role of Tai Chi in aerobic exercises, and finally about meditation and its role, as you talked about the advantage of psychological well-being? Those are the three questions I had in mind. Thank you for a wonderful talk and for opening the door to the discussion.
Thank you, Dr. Callender. So let me start with the very first question. Those are very important and questions that merit some further discussion. With respect to geriatric age, we say that the age is actually arbitrary. It came out of Social Security, the age of 65. And you will realize that a 65-year-old in 2021 is not necessarily the same 65-year-old about 50, 60, or 100 years ago, because life expectancy is getting longer. And I don't think anybody here would think I'm 60-something years old. I'm over 60. And so people are living longer, people are living heavier. So the age of 65, whereas that age is the age at which we consider as somebody a potential geriatric patient. That is, you can seek out a geriatrician. But because people are living longer and heavier, anyone may choose to prolong or to extend the period of time during which they continue to see their primary doctor and not see a geriatrician. But again, the earlier you engage the geriatrician, the better, because then the geriatrician can begin to focus on things that are peculiar to older adults, so that some things may be preventable, so that you're not waiting until major illnesses creep on you before you start seeking out a geriatrician. Again, even though people are living longer and heavier, the earlier you seek out a geriatrician, the better, so that he or she can focus on disease prevention and those things that are very peculiar to a geriatric population. So in a nutshell, the age is 65, above 65. With respect to meditation and Tai Chi, one of the major determinants of well-being is inflammation. So not only does Tai Chi is a type of exercise, but the meditation combined with Tai Chi has a profound effect on your neuroendorphins and your psychological well-being. It does reduce the level of inflammation, and anything that you can do to reduce the level of inflammation in your body is ultimately beneficial. Inflammation is the #1 killer. It's at the core of every disease that bedevils humans, from memory loss to cancer to hypertension to diabetes. There is almost no disease entity in which inflammation does not play a role. So anything that you can do to reduce inflammation, like meditation and Tai Chi, will ultimately benefit your physical and psychological well-being. Including going to church.
Oh, yeah.
One of my mentor and I published a paper several years back looking at the National Health Examination Survey and looking at church attendance and looking at how that correlates with cardiovascular disease mortality, death from cardiovascular disease. We were surprised to note that those who engage in regular church attendance, who regularly go to church and are religious, tend to have a lower mortality. And you can adduce spiritual reasons to that, which you will not be too far from being right. But from a scientific standpoint, we also know we tested the level of inflammation in those individuals, and we realized that they have a lower level of inflammatory cytokines because that data was collected in NHS. So we believe that lower levels of inflammatory cytokines must have been responsible for a lower rate of cardiovascular disease-related death, because if you believe in the ultimate of the one above and his ability to shape our lives, even though you're doing the best that you can, then your reaction and coping skills and coping mechanism is enhanced. And therefore, each time you have a life event confronting you, you don't allow the inflammatory cytokines and all the catecholamines to take over your entire physiology, because those things are like scavenger. They eat up the body. So anything that you can do, including if you believe in God, you go to church, you sing, you're happy, you produce neuroendorphins, you do Tai Chi, you meditate, all those things does reduce the level of inflammatory cytokines and therefore enhance both physical, social, and psychological well-being.
Good morning. I have a question, Carol Tatum. I have a question about medication for seniors. I know when my mother lived with me, the doctor was over medicating her. How come regular doctors or GP, they don't know about elderly or as you get older about over medicating? Do they look at all this medicine that you're bringing into this office? How come they don't know these things, regular physicians? Or how come they just giving all this medicine and placating us when they know that sometimes my mother actually looked like she got better by not taking all the medication, because she was in her 80s and she was taking one for menopause and all of that. So it just seems like some doctors just over medicate us. Is there a reason why?
Well, I don't think it's intentional. It's almost like saying a general surgeon. Why does a general surgeon not know as much as Dr. Callender knows about transplant surgery? It's in fact, some of the generalists may actually have the knowledge, but the sensitivity to some of these issues are not there because they've not been trained or sensitized to some of these issues. And it takes special skills and desire to know. You can imagine the mirage, the number of medications that are out there. It takes the desire to know and the sensitivity of the effects of this medication, to actually seek out knowledge on the side effects of this medication and be attentive to it when you are treating your patient. I will tell you a very short story. The first patient that I had here when I became a faculty at HU was an older lady who was repeatedly admitted to the hospital for diarrhea and dehydration. Well, the question was, why was she constantly having diarrhea and dehydration? She was not taking any water pill or diuretics. I didn't particularly know that the exact medication that she was taking at the time could be responsible. But as a geriatrician, as someone who was sensitive to the effect of, to the adverse effect of medications, I had to go and look up every medication that she was taking. And I realized one of the eye drop, not medication that is taken by mouth. One of the eye drop that she was taking was a medication we call carbonic anhydrase inhibitor, which is inhibit an enzyme that is present in the kidney, it's present in the gut, present all over the place. And because it's present in the gut, it's inherently, people think that if I put a medication in my eye, it doesn't get absorbed to my system. That is not true. It gets absorbed into the system depending on what medication it is. It turned out that the reason she was having diarrhea and repeated hospitalization, electrolyte imbalance, and admission to the hospital was because of this eye drop. I didn't even know at the time that it was the eye drop, but I cared to look it up as a geriatrician because I'm familiar with the consequences or sensitive to the consequences of medication. It turned out that that was the etiology of going through the revolving door. I called the ophthalmologist and I said, we need to change this medication to something else. The ophthalmologist agreed, we changed the medication, and that was the end of our repeat hospitalization. The reason I said that story is not so much to say that the journalists don't know, but the sensitivity to aging-related issue may not necessarily be there. And a lot of people train in different places and different eras, and knowledge is not static, it's constantly changing and growing. And then, in addition to that, we also have to consider the fact that there is so much pressure on clinical practice these days from insurance company, from everybody. You have to see X number of patients within a certain period of time. And that does not allow enough time on some occasions for the physicians to actually dig deep into what is going on because they are under pressure, especially those are practicing, those are in private practice out there. They have to see X number of patients per hour in order to meet their overhead costs. So it's a multi-factorial issue, but it's one that the American Geriatric Society is trying to work through because we realize that there are not enough geriatricians to treat everybody that becomes of age, especially with the baby boomers becoming of age. So there is a very elaborate effort to make sure that the generalists are also sensitized and provide with appropriate guidelines with which to treat older adults. The other problem is that when many of these medications are being tested, you will recall that I elaborated on the differences in physiology between the young and older adults. When many of these medications are being tested, they are not necessarily tested in older adults or people with multiple medical problems. Who are the people who are going to be, the people that are going to be using the medications for the most part? They're tested in younger, healthy population. So some of the side effects that emerge, really, they may say it's present in about 1% of the situation, when in actual fact, if an older patient takes that medication, or if a population of older adults take that medication, maybe 5, 10, 20% of them may have that particular side effect. So this is a multifactorial that we're all trying to work through and do the best that we can.
Okay, thank you. And I got one more question. I know, including my husband, when they go to the hospital with all their medications, and then the hospital changes the medication that the doctors have given, it sometimes leaves a quandary on who do you follow, the hospital or your personal physician. I just working with a young man who's around 56, and when he went, he was taking one thing, and then when he got out of rehab, he was taking something else. So what do you advise people to do? Follow the directions of the hospital or discharging medical facility, or by your personal physician? Who should know more?
That's a very, very most appropriate question. It's a fairly complicated response that I'm attempting to enunciate. When you leave the hospital, or when you go to the hospital, you go to the hospital because your medical circumstances changed. Something changed. Something was not working right. And therefore, the medication that were prescribed in the hospital are supposed to remedy that situation. For example, you could be taking 10 milligrams of blood pressure medication, and then your blood, for some strange reasons, your blood pressure drops below normal, and you become dizzy and you go to the hospital. And then when you're leaving the hospital stops your blood pressure medication. The question is, did the hospital do the right thing in stopping that blood pressure medication on temporary basis while you are leaving the hospital? I would say the answer is yes. But should you continue to not take that medication? That is the determination. That is where your primary care physician comes in. That is why most hospitals will say, make sure you see your primary care physician within a specific period of time. So it is the responsibility of your primary care physician to look through that medication, to look through the history of why you went to the hospital, what happened in the hospital, and why your medications were changed, and then to make an informed decision as to what happens to your medication from that point on. It could very well be that you have to stay on the hospital prescribed medication, or it could be that those medications have to be changed, again, depending on what's going on. For example, another example might be a lot of people go to the hospitals, they get placed on H2 antagonists, antacids, and so on and so forth for presumed gastric distress or peptic ulcer disease. The recommendation of the American College of Gastroenterology is that those medications should be used for no more than 6 to 8 weeks. If your doctor is not vigilant, or you haven't brought that to the attention of your doctor that this medication was changed while I was in the hospital, or these are the medications that were given to me while I was in the hospital, and to review the record to see why those medications were given to you, in order to make an informed decision as to which of those medications stay and which of them gets continued during that visit, or maybe allow a couple of more weeks, or maybe have a couple of more visits before those medications are adjusted. So human physiology is not very static. Things are constantly changing, constantly happening. So your primary care physician has the final say in your management on a long-term basis. But as at the time that you went to the hospital, I think it's appropriate that you just do what the hospital say until you see your doctor. And the doctor can review why you went to the hospital, what happened in the hospital, what you are given, why you are in the hospital, and then decide what the next step, appropriate next step is.
Doctor.
Yes.
Go ahead. I'll wait. Go ahead, whoever it was. Answer. Okay. Doctor, thank you very much. You've given excellent presentation. I truly appreciate it. I'm Chaplain Thorpe, and as a chaplain, I get a lot of these questions, especially the elderly people in the churches, and at in the hospital. And one thing about the safety you talked about, that is priority. And so I have patients, and they don't have to be ashamed. In 60s and 70s, they say when they have to get up to go to bathroom once or twice, they have a tendency to fall. So they keep a urinal, female urinal, male urinal, or they have a little bedside commode. I think that's an excellent idea, instead of walking to the bathroom, and I like that safety thing. And the other one was that you talked about having that, what is that? Oh, I'm 74, I'm forgetting too. The thing that you write down, living will, I'm sorry, yes.
Yeah.
Yes, you're so correct, doctor, because we're caught in the middle in the hospitals, the chaplains, because it's families fighting, because they didn't, they didn't have the will, who's getting who and all that kind of stuff. And also they may have living will, or they may not. Okay, if they have that, then they don't have what goes to whom. And like you said, it wreaked havoc in the family. Everybody is divided. And then in the end, after funeral, nobody's talking to anybody. And sometimes the wife, gets stuck with all the medical bills and the, funeral bills. And it just happened to my friend 2 weeks ago. Her husband died. She's only 52 and her husband was 70, So you are so correct. And I hope people take your advice. Please, everybody, make your plans. The doctor is telling the truth. He's telling us, so we won't have this kind of problems in our family. He is excellent doctor. I want everybody to listen to him and do this. Make your plans for your future, for your funeral, where you want to be buried, even make up your program and everything about your money and everything. So there will be no family feud and no stress. This doctor is excellent. And go to church, everybody, everybody. It's so good for you. Not only Sundays, Tuesday, women's Bible study, Bible study, prayer studies, Friday this, Saturday this. Thank you, thank you, thank you.
Thank you for those excellent observations. I feel very passionate about the view and idea that your life, worth, sweat, and blood should not go to lawyers. It should go to your next of kin, whoever they are. That I just feel so passionate about that. And because of we historically don't have a lot of generational transfer of wealth as a population, as a people, and we shouldn't be propagating that process. And if you want to donate it to charity, so be it, donate it to charity, but it shouldn't be left to enable, it shouldn't be allowed to enable a discord among family members. One other observation I want to make, in addition to the urinal and getting up in the bath, getting up at night to go to the bathroom. One thing you can do to decrease that propensity is to make sure you drink as much water. It's very important that you drink water, I must say, because many of us, whether young or old, do not drink enough water. So it's most appropriate that you drink a lot of water. But please drink that water during the hours of the day, between maybe early in the morning until about 4 p.m. in the afternoon. After 4 p.m. in the afternoon, you should decrease the amount of water you drink, because getting up at night to go and urinate, it's a very, very high risk proposition, because that is when most falls occur.
Yeah.
Again, I said I would only have one more question, but as far as living will and etc. and depression, and a loved one is going into depression and they want to end life, and they're depressed and you really don't want them to end the life, that seems to be oxymoron. They want to end it because they're depressed, and you're hoping that their depression will go away for them not to end it. Doesn't that cause a conflict? And that's where a lot of people, they're depressed, they want to end the life, but the family know they're depressed and they don't want them to end the life.
So I guess the underlying issue we're trying to point out is that desire to end one's life. Is that being made in clear consciousness, or is that being promoted by an underlying disease factor? Everybody has the right to make that decision, but we are hoping that that decision will be made in clear consciousness. The problem with depression is that depending on how you define consciousness, their thought process is not optimal at that particular point in their journey, because that decision is being made based on some neurochemical imbalance that is going on in the brain. And therefore, that decision cannot be considered rational. If someone is happy and joyful and everything is well, even though you cannot take you cannot take some of those things for face value. The fact that somebody is laughing does not mean they are not depressed. So appropriate assessment has to be made. If someone is depressed, I don't think it's appropriate to let that person harm themselves just because we think they have the right to harm themselves. Nobody in his right mind wants to harm themselves. So if someone is not operating within the confines of what we consider right, then how can we say the decision that that person is making is correct, the right one? We don't think it's the right one. After the person has received treatment and is clear consciousness and no depression, and the person says, oh, I've had enough, I've had a good life, I don't want to live anymore, then the person has the right to that decision. But I don't think that's the norm. I don't think a normal person who's well, healthy, and happy will say, I want to end my life. So the question is, what do you do under those circumstances? The best thing is to get them to the doctor. You can also call adult protective services if you're having difficulty in getting them to see a doctor. You can call their favorite pastor to talk to them. Whatever it is that you can do to get that person help is what you do at that point. It is an acknowledged fact that majority of people who end up committing suicide have spoken to somebody about it. So the question is, if someone tells you I'm thinking about killing myself, is it appropriate to be quiet about it? No, I don't think it's appropriate to be quiet about it. You have to get that person help.
Good afternoon. It's still morning. I want to take the topic back to the medication for a few moments. I heard you say that you should take the medication to your doctor, but then after Carol's question about the primary doctor maybe not being able to give the time, to the medication, I'm wondering if it is better to talk to your pharmacist. If you have a good relationship with your pharmacist, would they be able to determine if you took everything to them?
The practice of pharmacy is actually rising up to the occasion. There are pharmacists who are licensed to provide additional counseling and medication management. Yes, it's appropriate that you talk to your pharmacy, but I still feel that the most appropriate person to engage in that discussion is your primary care doctor. And the reason is simple. This is the person who sees you as a human being, who sees you as a complete person, who knows about your hypertension, your diabetes, cholesterol, whatever social psychological issues may be going on, whether you have money to buy the medication or not, all kinds of the dynamics that affects your well-being. So that person is using a lot of patience, both in his consciousness, and those that are not even in his consciousness, but because of his knowledge of you as a person, is using that information to make decisions about your well-being, and also has complete medical information on you. The pharmacy just know your diagnosis, and it just know the medications that you're taking. The pharmacist doesn't know a whole bunch of things about you that will influence the decision as to which medication to take, which one not to take. So I think yes, it's appropriate to speak with your pharmacist, but it's still most appropriate that you talk to your doctor. Even though I underscore the fact that doctors are busy, I don't think there is any doctor that you would take all your medications to and say, here are the medications that I was taking. Here are the ones that I just prescribed while I was in the hospital. Can you tell me which of these medications I should continue to take? Almost every doctor I know will pause a little bit and take a look at those medications to make sure that there are no medications that are contraindicated to your medical well-being.
Dr. Obeseason, this is John
Yes.
Tatum.
Mr. Tatum, thank you.
Yeah, thank you for coming. I've enjoyed your talk very much, and I've learned a lot on just this one call. I wanted to get back to the subject of polypharmacy. One of the reasons why the lifespan has increased is because of all of the new medicines that we take. You mentioned one about helping a little bit with diabetes. I mean, not diabetes, but Alzheimer's. There's a medicine out there that can help you with all sorts of things. New medicines that are out. There's a medicine out that helps you eradicate hepatitis C. And so for those new medicines that are out there on the market, is what's causing us to live longer, have a longer lifespan overall. COVID has come in, and COVID has shortened it a little bit, but I think the overall polypharmacy business has increased it. But let me get to my question. As we age, the effect of these medicines either increases or decreases. I think it increases, really. I'm not sure, you can correct me on that. I think the effect of the medicines increase. So the question is, does that mean that as we get older, we need to decrease the milligrammage of the medicines that we take because they have a stronger effect?
That's a very interesting question. Let me begin my response by noting that my observations on polypharmacy was not intended to make medicine a bad guy. As you correctly pointed out, much of the advancement in age, longevity, and extension of life was due or is due to mirage of new surgical procedure, instruments, surgical instruments, assistive devices, as well as medication. New medications continuously get to the market that are better than previous ones. The point I was trying to make is that yes, these medications are purposeful, they are helpful, life, but we have to be judicious in the way we use them because they are not without side effects. Even water, if you drink too much water, you can get water intoxication. We know alcohol is beneficial, like if you drink red wine, potentially you can reduce your cardiovascular disease risk. But that does not mean that if you drink too much alcohol, that you cannot damage your liver. It also does not mean that if you are particularly sensitive and you eat cheese and you drink wine, it doesn't mean that you cannot get arrhythmia, abnormal heartbeat, because of you eating cheese, you eating pizza, and you're drinking wine at the same time. So yes, medications are desirable, they're beneficial, they are useful, they extend life. The point I was trying to make is that we have to be judicious. And that another important point that you touch on is that the physiology of an older person is slightly different from that of a younger person. Most of these medications were not tested in older people, nor were they tested in people who have multiple medical problems and using multiple medications. In fact, for many of these studies, these were exclusion criteria. But guess what? When the medication comes into the market, guess who use the medication? The people that have multiple medical problems and on multiple medication. So the propensity for drug-drug interaction becomes heightened. To your specific question on whether medications have more or less side effects, again, it will depend on the type of medication. For example, a medication that is soluble in an environment that is alkaline is going to be more bioavailable. It's going to reach a higher concentration when you give it to another person because the stomach acidity changes with advancing age. So if a medicine was tested in the younger people who have a lot of acid in the stomach, and the medication is only 50% bioavailable, that is, if you take 100 milligrams of that medication, only 50 milligrams of that medication becomes available to work in your system. That was that could have been the basis of the formulary. However, if you give the same medication to an older patient who has less acid in the stomach, who in fact has the stomach content is alkaline and is taking H2 antagonist or PPI, then that medicine, the available component of that medicine may double or triple for that person just because of their unique situation and circumstance. So this is why it's critically important that clinicians and geriatricians have to be sensitive to individual needs because one shoe does not fit all in this issue that we're discussing, which is why your primary care physician is the person who knows the most about you and therefore is able to reconcile all those things and determine the best course of action.
Thank you for that answer.
Can a dermatologist be your primary physician?
Yes, if you can find one that's willing to assume that responsibility, yes, a gerontologist can be your primary care physician.
Well, are there any more questions? This has been a wonderful presentation that has addressed many of the issues. Any other questions?
Well, just a comment to Betty. I was wondering, because the last time you talked to us, put a question mark whether my primary care was actually giving me all the best services. And I did obtain the services, Dr. Avisa, just to give me that sound mind of whether or not, you know, your primary care and you're getting the best services and everything is being diagnosed and correctly. And we've had talks on this panel before, what to look for when you go to your doctor, et cetera. And are you getting all your vaccinations? And they're telling you the things to do that might be overlooked. So sometimes you can get another consultation with a geriatric along with your primary care doctor.
Well, that's a very viable and good option. But to your question on what to look for when you go to your doctor, I start with you as an individual, because there is so much we can remember from minute to minute. One thing I will encourage each person to do the day before you go to see your doctor, write down a list of things that you want your doctor to address. Let your doctor finish his evaluation and then go through that list one at a time, so that if he needs to do another additional assessment in order to address your question, that will be done before you leave the clinic. And also, as I pointed out, go with all your medications and ask the doctor, is there any of this medication that I can safely discard? Or is there any of this medication that you can combine, multiple medications that you can combine into one? Because clearly, the higher the number of medications that you take, the greater the likelihood of drug-drug interaction and potential for adverse consequences from those medications. The other thing you should look for is listening ability. You want somebody who will listen to you, not necessarily argue with you. Listen to you to understand where you're coming from, and then ask you questions to further understand what you are thinking. And then obviously spend some time reconciling your records.
Hi, this is Sylvia, Dr. Thomas. One question I have is, when is too much water bad for you? You have some people say I drink a gallon a day. How much water you should drink, and some people go on water diets. When is too much water bad for your system?
That's a hard question for me to answer, because I know for a fact, based on the literature, that an average person, most people do not drink enough water. But if you are drinking too much water, then you have to ask yourself the question, is there another problem enabling this insatiable desire for water? Yes, drinking a lot of water is good, but there are medical conditions that can predispose you to wanting to constantly drink water. For example, if you're diabetic, you're drinking, you're passing it out in urine all the time. You have a particular adrenal problem, you can also be drinking a lot of water. So I think the important thing is to discuss with your doctor, let him know how much water you're drinking and your desire for water drinking. To tell you how much water you should drink a day, because most of us don't drink enough. So to even tell you that you should drink less than this, it's challenging. However, if you have a heart condition, like if you have congestive failure, then that's inherently limits the amount of water that you should be drinking. Maybe perhaps your doctor may decide to put you on water restriction.
Thank you.
There's a chat in the chat room, and I don't know if the doctors have been to the chat room. Do they have a comment about that? Dr. Callender and Dr.
Let them ask their question, whatever the question
Okay.
is.
Are there medicines that interfere with the COVID vaccine?
Yes, I asked that question, Sylvia. When we were talking about medications, I was just
Mm.
wondering, encouraging everyone to get the COVID shot. I don't, is there any medication that's kind of interfering with the COVID shot? I don't know if that's information you
So to be candid, I don't know the answer to that question, but as a clinician and a scientist, I will venture to say that if you take any medication that can lower your immune system, that impacts on your immune system, like steroid, taking cancer chemotherapy, any medication that can affect your immune system is likely to affect the COVID vaccine. That would be a very generic response.
Well, thank you very much. It's been a very provocative discussion that has allowed us to interact well with you and to answer all of our questions. And we have to thank you so much for once again being spectacular in terms of addressing our needs, as most of us have reached that geriatric age. There are exceptions, but most of us have reached that age. And so we deeply appreciate you taking the time to educate us.
Thank you for the privilege and the opportunity to share a few thoughts with the group. Appreciate it.
Thank you, everyone. By the way, Cheryl Jones was discharged yesterday. She went home, so she's doing better. And we talked about John Robinson's death, and he had a private funeral. And we'll miss him muchly as a psychologist who contributed greatly to the group, but will be missed very much. So thank you, everybody, and see you next week.
Thank you.
Bye.
Thank you.
Thank you. Very good.
Very nice.
Thank
Beautiful.
you. Enjoyed
Yeah.
it.
Age appropriate.
Yes.
Right, John Buchanan? Age appropriate conversation. You're muted.